Hello, everyone. Thank you for joining us today on this episode of BAEP Talks with. This is a 30-minute discussion with a person of interest who lives with, manages, treats, and/or supports others with a chronic menstrual health disorder. My name is Julia Mandeville. I am the co-founder and the public health and advocacy manager of the Barbados Association of Endometriosis and P.C.O.S. And I'm your host. Today, I'm joined by Dr. John Barker to have a discussion about adenomyosis, also the importance of a multidisciplinary approach to health management and everything in between. So about Dr. Barker. Dr. Barker is currently a specialist obstetrician and gynecologist and has been a consultant in the UK since 2013. He is currently a consultant obstetrician and gynecologist at GRB Medical Center in Barbados. He has completed his postgraduate training in the UK via the Mercer Deanery. Did I say that right, Mercer?
Yes.
Rotation in Liverpool.
Yeah.
And has obtained his certificate of completion of training. He has worked at multiple hospitals in the UK, including the largest standalone women's hospital in Europe. His areas of interest include gynecological oncology, benign gynecology, endometriosis. He founded the Endometriosis Center at the GRB Medical Center with a multidisciplinary team, so that's why we want to talk about the multidisciplinary approach. He's also interested in emergency gynecology and obstetrics. He is a member of the Royal College of Obstetricians and Gynecologists, British Society for Colposcopy and Cervical Pathology, International Society for Sexuality and Cancer. He's also, with all of that, been a registrar in obstetrics and gynecology at the Queen Elizabeth Hospital between 2003 to 2006. Welcome, Dr. Barker. Thank you
for having me
today. Thank you. So let's just, jump right into it. We hear the term adenomyosis. What is adenomyosis?
Adenomyosis is essentially where the lining of the womb is actually found inside the muscle of the womb. Now, they do not know the exact, what we call the pathogenesis of it. So there are like various theories. Sometimes it can be congenital. Sometimes, when we say congenital, mean that when the womb is being formed, you get these pockets of the lining of the womb inside the actual womb itself. Sometimes if you had what we call a DNC with a sharp curette, sometimes that can predispose you to adenomyosis, because sometimes you get injury to the lining of the womb and the muscle, but this only occurs in pregnant uterus, not in non-pregnant uterus. Yeah. So those are like some of the common theories, but essentially they don't really know exactly how it comes about.
Okay, so we can't generally like pinpoint who may possibly get adenomyosis. Like we can't say with any.
Well, it is congenital in some cases. So like, congenital, and it is familial. So like, if your mother had it, sometimes you have a small probability that you might get it as well. Yeah, but it's not conclusive that you will get it.
And it only affects women?
Yeah, only affects women. Only affects women.
So what is the relationship between adenomyosis and endometriosis? So for me, I was diagnosed with endometriosis, and then after that diagnosis, I was hearing all of these other terms. So yeah, what's the relationship between those two conditions, if there is?
Right. Endometriosis is where the lining of the womb is found outside of the endometrial cavity. So it can occur anywhere in the pelvis, anywhere in the body, for a matter of fact. But interestingly enough, up to 24% of patients with adenomyosis will have endometriosis. Yeah. Adenomyosis is also found other conditions like endometrial polyps, fibroids, and stuff. So even though you might have adenomyosis, you might have other pathology as well, with the more likely two culprits being fibroids and endometriosis. Adenomyosis doesn't really cause infertility as such, but if there is endometriosis, then there's a component of infertility as well.
Okay, so Happy that you brought up infertility because this week is being recognized as National Infertility Awareness Week. So maybe further on in this discussion, we can talk a little bit about that as well.
Yes, please.
So how exactly would adenomyosis be diagnosed? Is it different from the diagnosis of endometriosis? And then how so?
Right, right. And adenomyosis, usually you would either get two major symptoms, which would be heavy periods and painful periods. Yeah, the painful periods would be because every month the lining of the womb that is actually inside the muscle, you would get like bleeding inside the uterine muscle. So that's where the severe pain comes from. Yeah, and you also to get heavy periods because sometimes because there are two different types of adenomyosis. So there's a diffuse type whereby the womb is quite big, and then there's a focal one. But usually in the diffuse type, the womb is quite big. So as a result, the uterine cavity is bigger. So that's how that's why you get the more heavy periods, and you get the painful periods because of the bleeding inside the muscle. When you compare it to endometriosis, you can get painful periods, but usually the characteristic difference would be pain when you're having intercourse, and sometimes you can get pain all through the month, which then gets worse for your periods and then comes back down. And so you get constant abdominal pain with endometriosis. So that's why sometimes it's difficult to diagnose adenomyosis, because if you have the two pathologies, it will present quite similar. So, but you don't really get heavy periods with endometriosis. So that's the determining factor. But if you have the two pathologies, then you get heavy painful periods, pain throughout the month. So you gotta be suspicious for it, because sometimes you might not actually diagnose it. You might actually miss it because you're not looking for it.
Right, because you're trying to treat the endometriosis, which is presenting
Correct.
readily. And then you said there's diffuse and then there's focal. Are there any characteristics that differ between women that might only be diagnosed with, adenomyosis between these two types of adenomyosis, or it just varies?
Oh no, that's just the two types of adenomyosis and how they present, but the symptoms are the same.
Okay.
Yeah, symptoms will be the same.
Okay, so is there a cure for the adenomyosis?
Well, before we get to the cure, it all depends. Like when we take the history, it all depends on how old they are, if they're looking to get children, etc. So when we examine you, what happens is that characteristically the womb is bigger and smoother. Yeah, so that's how we think more likely is adenomyosis, versus if the womb is fixed, which could point towards endometriosis, because it can get a lot of scar tissue with the endometriosis. Now, in terms of the cure, the problem with adenomyosis is that it's a histological diagnosis. So the only way that you can diagnose it is a hysterectomy. And not all women will want a hysterectomy, especially if you're fertile or you want to get treatment, right?
Yeah.
So what we usually do in the standard examination would be to do a ultrasound scan. And there are certain features when you do the scan, the ultrasound scan, that will point you towards it. And usually what I tell people is that if you can't diagnose it on the scan, on the ultrasound scan, which is an internal scan, because you do the internal scan because it's more sensitive, rather than the abdominal scan, then you have to do a MRI, and the MRI would be more sensitive. So that's how we would diagnose it beforehand. Now, in terms of cure, if it all depends on if the patient is within wants to preserve their fertility. Now, if they want to preserve the fertility, then the options usually are hormonal, which should be like the oral contraceptive pill. And essentially what this does is to thin the lining of the womb, and it will thin the deposits within the uterus. So as a result, you will get like decreased bleeding, you will get decreased pain. Sometimes you can give other medication like tranexamic acid and mefenamic acid, which you would use incidentally for like heavy periods with fibroids and stuff. And essentially what it do is to decrease the blood loss. So it doesn't actually cure it. What it does is just
manage it better.
How you manage it medically. Now, if however the person has what we call the focal adenomyosis, This is just like a circumscribed, what we call like a fixed mass adenomyosis. Sometimes you can excise that, but that is not a common thing. The diffuse is harder to treat because it is by nature diffuse, so it'd be all through the womb itself, and that would be harder to treat surgically. If fertility and also too hormonal would be the Mirena coil.
Okay.
Now the Mirena coil is like a T shape, like a copper T, and essentially what it does is release a hormone inside the womb, and what it does will be to thin the lining of the womb as well, in addition to the deposits inside the actual uterus itself. So it would actually cure, but it will help you manage it. If, however, fertility is not an issue, then, well, before I get to that, the last component of the conservative management in relation to conserving the womb would be uterine artery embolization. Now, what that is that it's a radiological procedure. So the gynecologist doesn't do it. We would refer you to a radiologist. And then what they do is block off some of the blood flow to the actual womb itself. And then it will shrink the deposits of the adenomyosis.
Sorry, not to cut you off. Is that similar to something that happens with uterine fibroid treatment as well? I thought I heard something.
Yes. Uterine artery. Okay, it depends on which side of the pond you are, because I was in a conference and I was telling them, well, if you are in UK, we call it uterine artery embolization, and that encompasses treatment of fibroids. If you're on the US side, they call it uterine fibroid embolization, but it's essentially the same technique. It's just it just depends on which side of the pond you're on. Yeah.
Okay, thank you.
So yeah, no problem. So that is one of the modalities. But when you do uterine artery embolization, you have to counsel the patient very carefully, because sometimes you can get premature or ovarian failure with that as well too. I think it's around 3%, but you have to counsel them. But they would still be able to get pregnant. But as you said, you have to counsel them, because if, for argument's sake, you have other pathology like fibroids, the evidence would suggest that a myomectomy would be more effective at getting pregnant than uterine artery embolization. However, the myomectomy is more invasive versus the uterine artery embolization, and the pregnancy rate with the myomectomy is higher than the uterine artery embolization. So once you counsel the patient, then they make the decision, but you have to counsel them very carefully.
Right.
Surgery wise, if they want to keep their uterus in, you can offer them endometrial ablation, whereby you put a small balloon inside the womb, and essentially what it does is destroys the lining of the womb. And this is for like superficial adenomyosis, because adenomyosis can be superficial, right? It can spread all the way through the uterus itself. Yeah. So the endometrial ablation, which is a new technique to the Caribbean, that can be offered as well. And then after that, then it would be hysterectomy if the patient doesn't want to preserve fertility.
Okay. Well, that was extensive, but thank you so much. So when I first started hearing about adenomyosis after my endometriosis diagnosis, with endometriosis, you see that it was initially thought to be the career woman's disease, when it was initially, initially, it was a condition where women established a career and then they were trying to get pregnant and then they didn't, and, we moved from that. But then now, when I've heard about adenomyosis, initially I was reading up that it was mainly a condition, again, that occurred in women close to menopausal age. Is that still the case, or are you now seeing maybe more patients that extend throughout the years, like from teenage years onto menopause?
Yeah, sorry, Costa. The adenomyosis usually presents around 40, 50 years of age. And the reason for that, we're not exactly sure, but usually around 40, 50 years of age. And usually when they present, they would present with the heavy periods and the painful periods. And sometimes the actual ultrasound scan wouldn't show any fibroids or anything like that. So you actually have to be suspicious of it. And if you don't, and if you suspect it and you don't say ultrasound, then these patients might benefit from an MRI.
Okay. So you said usually, but have you been engaged with persons that were like teenage years, 20s, 30s that had presented with adenomyosis and then?
No.
Okay.
No. Most of them that I see around 40, 45. I just did a hysterectomy a week or so ago, and she had adenomyosis as well. So I think I have put it on the website. But yeah, it's a big.
Oh yeah, I did see that, and then we can direct persons to the website, the social media.
Not website, Instagram.
Social media, right? But disclaimer: it is shocking. I was very surprised when I saw the size of it. But this is why we're doing this, because we need to be educated about the fact that these conditions occur, and this is the outcome. If we don't talk about the possibility of these things occurring, and that leads me into my next question. So based on the fact that you grew up, well, we grew up as young girls, women, and we're taught one thing in society, basic things about, the menstrual cycle and reproductive health. And then we're then basically hit with all of this new information that really isn't new. It just wasn't given to us at a younger age. Right. At what age do you think young people, and I'm saying people are not just girls because we don't live in silos, it's a co-ed, for better term, society. So at what age do you think young people should learn about these conditions, these reproductive health conditions, and these menstrual health disorders?
Well, I would say when the young teenage, well, as soon as become teenagers, to be honest with you, 13, 14, especially when they start their periods, if painful periods are not normal, so what I would suggest is that anybody who has any issues, luckily enough in Barbados we have adolescent pediatric gynecologist. I would suggest, or actually implore, that any young female who has any issues to be seen early, especially if they got painful periods that don't settle, so that you can actually get a proper diagnosis to begin with. Because you have to remember that most young women they spend about between 7 to 15 years before they're diagnosed with endometriosis and stuff. So for me, the earlier diagnosis is better. And I don't mean that we'd be doing surgeries on like 15-year-olds and stuff, but I mean, as long as they're within the system and stuff and being seen, then when they become like 16, 17, 18, then you can decide if to go ahead and do the laparoscopy. But at least they're actually known to the adolescent pediatric gynecologist.
So you're saying painful periods are not normal. How does one differentiate between pain and discomfort? So I know my pain threshold, but as a clinician, as a doctor, and someone is presenting with you, you're not feeling what they're feeling. So
no.
Yeah. So guide us through how do you differentiate between it being, I'm going to use the clinical terms, primary dysmenorrhea versus secondary dysmenorrhea.
Right. So primary dysmenorrhea is like when you don't get your period and it's not attributable to anything, whereas the secondary is when you have like fibroids and stuff. Yeah. So essentially, if a young lady getting your periods and you get mild cramp, so if you're using paracetamol and stuff, then and it settles, then that's fine. However, if you're getting cramping, because you must understand that the cramping that you get is due to the uterus trying to get the blood out. So depending on how much blood in there and stuff, the uterus will cramp. But if it's that severe that the analgesia isn't working, the simple analgesia isn't working, and particularly if you're taking a lot of time off from school, you have to go and see a doctor. I wouldn't say that is normal, or you have to go and see someone. Even if they reassure you and do an ultrasound scan, fine, and then we go from there.
Okay, and so then also parents need to be educated about the things that should be.
Yeah, because for me, I'm a gynecologist, but you're a gynecologist and then you're a gynecologist. My specialty doesn't encompass adolescents, so it's not my specialty. So I would refer them to somebody who has more experience than me. Yeah.
Okay, so you're helping leading to my next question. So thank you for that. So the next question is, are gynecologists the only specialists that should be involved? So you did say you have a pediatric or maybe an adolescent gynecologist,
Yes.
but what are the other types of specialists that should be involved, in your opinion, when dealing with these types of gynecological conditions like adenomyosis and endometriosis?
Right. Now, traditionally, the gynecologist was the head person to deal with it. But as you get better specialization and better understanding of the disease process itself, the multidisciplinary team is the way forward, because what a urologist might know or a surgeon might know, I might not necessarily know the best way, but they would know the individual aspects of their field. So say like for endometriosis, if you have a young lady presenting early, like in the teens, then the best person for them to see would be an adolescent pediatric gynecologist. If they are like adolescent to adult, then a general gynecologist can see them with an interest in menstrual disorders or endometriosis. And the reason for that is that people who have special interests would see these things day in, day out. So the little peculiarities that someone might miss will be actually commonplace for that person. So to begin with, you have the adolescent pediatric gynecologist, then the normal gynecologist. If for argument's sake, you have any, and this is like for endometriosis or adenomyosis, if you try to treat a lady conservatively and they want to preserve their uterus and they don't want surgery, then you have to, and they don't want medical treatment, then by default it goes to uterine artery embolization. And that would be in the specialization of interventional radiologists, because those are the people who do that. Now, if you have like deep infiltrating endometriosis, whereby you get the bowel, the rectum being involved with the uterus. So actually between the rectum and the uterus is a space called the pouch of Douglas. So when that's frozen.
Yeah, I know that very well because I have deposits there. So yeah.
So when you have that type of pathology, that is serious pathology. That entails a gynecologist and a laparoscopic bowel surgeon to do that surgery, because that's very complex surgery, can last like 5-6 hours. So this is how the multidisciplinary team comes into play. And then we would have like meetings to actually discuss these individual cases, to actually make a management plan. And that's the difference, because you don't just go into a surgery or a situation and say, oh, well, let me call this person or what. So we do the necessary investigations before, so we know exactly what we're going in to do. And similarly, like urology and stuff, because if you have the deep pathology and stuff, you might need a urologist to either stent the patient, or you might need them if they have the anterior part of the anatomy, which is the uterus and the bladder. If that's stuck, then they might actually have to come in to actually take off the scarring and stuff from the actual bladder as well. So the multidisciplinary team is very important. And then there's the psychological aspect, because most people can't get pregnant, so they might have psychological issues, and then they have chronic pelvic pain. So it not only affects them, but it affects the whole family. And then there's the physical side. So this is where the physiotherapist and stuff comes in, and pain management, and then that's where for the pain, then that's where the pain people come in, like the anesthetist with the specialist interest in pain. And then after we do the surgery, then because most, like if you're dealing with endometriosis, the issues will be after surgery, because if you want to get pregnant, hormonal therapy doesn't work, you got to do surgical therapy.
Mhm.
And then this is where the fertility people will come in. So in a short space of time, we had about 8 different
Special.
specialties actually, yeah, coming in. Yeah. So sometimes it can get very complex, and especially, like the simple endometriosis is fine, but when you actually get to all the deep infiltrating stuff, then that's where it becomes very, very complex. But the surgeries are available in Barbados now.
Okay, that's
In,
good.
in
So
terms of, in terms of doing it.
yeah, so we're talking a lot about the traditional approach to medicine. I'm not sure if this is going to be a touchy subject, but what is your take on complementary medicine as it pertains to treating and managing these conditions?
Right. Now, the it's not that you have anything against it. The problem is that most doctors would not be trained in alternative medicine. You know what I'm saying? What I would tell patients, I would do a disclaimer. I would tell them, well, it may work or it may not. I haven't seen the evidence for it, so I can't actually say, well, this works based on this trial or this trial.
Right.
All right. And that's why I tell people, because at the end of the day, you might have like a small percentage, like 1, 2, 3% that it works in, but I don't knock it. I say, well, at the end of the day, just make sure you read side effects and stuff.
Right.
But I can't actually say, well, it works. This is what to do. This is how much to take, because honestly, we're not actually trained to actually give
Do
it.
that.
You get what I mean? But in terms of, I would tell them, well, if you're taking it, make sure that you understand your side effects and stuff. But I can't say, well, this is what you do.
And not just the
Yeah.
side effects of that, but then they could be interactions between
Interacting with other
medication
drugs and
and the medication you might be prescribing them as, a traditional.
Yes,
So
yes.
I would think that regardless, they should, if they intend to, use an alternative method, they should still have that discussion with you as their physician, so that right, so that they could have that discussion as to whether or not there are going to be any negative implications with mixing the medication.
Yes, please.
Right.
True.
So as the first point of contact for many people seeking medical attention are primary care physicians and nurses, what can be done to ensure that they know more about menstrual health disorders and to direct persons to specialist care if or when it's needed? What do you think should happen in the system to, have that line of communication?
Yes, what the model that we do in terms of, there's a direct referral. So if, for argument's sake, if anybody, like, you can go on Instagram, Facebook, Google, whatever, you can do a direct referral. But the issue is the education of the patients to know exactly what is out there, because sometimes you might have a service and nobody besides a few people might know about it. Do you get me? And the thing is that when you tell people, well, this service exists, like, whoa, I never knew that, but it does. So like, you have to educate the public, so at least they know exactly what is out there. The patients, in terms of GPs and stuff, yes, they can see them. They do a short trial, like 2 months or so. If it doesn't work, what I suggest is that quickly you refer them. The nurses, they would have an idea, so they can say, well, you go this place, or this place. But it should be direct referrals, or GP 2 months and then go. But depending on how comfortable they are, because there's no shame in saying, well, I don't know. You can go to this person, they will know, or they know how to handle it. So something like, for me, I would say, well, this stuff, I might not be the best person for it, but you go to this other person. Yeah.
And I think, well, I would appreciate that as a patient, because you're being honest and you recognize that someone else can give me the better, a better quality of care than you. And that's fine. There's, like you said, there's no shame in doing that.
No.
Okay. Well, I also want to touch quickly on costs and finance. I know, like, that might not necessarily be your specialty, but are these conditions expensive to diagnose, treat, and manage? And then, if so, should that cost be a barrier or burden to treatment?
Well, no. For argument's sake, in terms of the non-invasive investigations, the ultrasound is relatively affordable. Depending on who you go to, it might be in your best interest to see a gynecologist from the get-go, because when you do the cost benefit analysis for that, you actually save 50%. But everybody is different. But a direct system referral actually saves you money, because if you go other places, you have to spend that amount of money, and then you have to come back to then double spend again. So if you go straight ahead, fine. The only issues with the other investigations would be like the MRI, depending on if you're going that route, then that might be the more expensive option. Medical treatment, for the most part, in relation to oral contraceptive pills and Mirena, those are essentially the same. The only issue with the Mirena is the upfront cost, but when you actually spread it over 5 years, it's actually cheaper than buying the pill every month.
Right.
Yeah.
Yeah.
Right. And in terms of the surgeries itself, it all depends on what you're doing, because for argument's sake, if you're getting the least invasive, it should be the uterine artery embolization. That cost varies depending on the person who's doing it, but it is relatively, I'm not exactly sure of the cost, but it is manageable from what I understand. But it all depends on how much is being done, because the uterine artery embolization is not like done frequently like a hysterectomy.
Right.
So it all depends on who's actually doing it. The major cost with the surgery would be the laparoscopic surgery, because that is, but it all depends on the type of surgery that you're doing, because a diagnostic surgery is by far cheaper than an operative, whereby you have to do like bowel, because sometimes if you have the deep infiltrating endometriosis, sometimes you have to do a resection and stuff. So it all depends on how much they have to do. But as you said, there are two different modalities of treatment in Barbados. There's the private or the public, and it all depends on if you're insured or not. But whatever is done. I mean, for me, like what we try to do is like we will try to like treat some person nearly free of charge or whatever, or if we work with some people, we get donations and then we try and do them. But that's what we do in terms of trying to give back. But it's all about the outcome. But the issue would be is that it's highly specialized care. So that's where some people might say there's the pitfalls, but to go forward, you have to increase the specialization of the treatment.
Yeah, understood. And so basically you're saying it will vary from person to person.
Right.
And another aspect maybe in the multidisciplinary care is the involvement of insurance. But might be another conversation for another time. But
that's private side. That's not on
the public side. Okay, great. Thank you so much. So Dr. Barker, that was really informative. Thank you so much. I believe that our viewers will now have information and be able to define adenomyosis, understand its relationship with endometriosis, be aware of all the different systems that can be impacted with these conditions, be able to identify the medical specialists that might be needed to be called on as it pertains to the multidisciplinary approach, recognize the importance of early education about reproductive and general menstrual health, and also appreciate the importance of ending the stigma around menstruation and the pain, because the only way people are going to seek help is if they feel comfortable to ask for it. So again, thank you so much for your time and sharing your knowledge with us. For more information about the GRB Medical Center, I will provide contact information in the description. So again, thank you so much, Dr. Barker, and to our viewers, I look forward to seeing you at our next BAEP Talks with session. Have a great rest of your day. Bye.
Thank you. Bye.
Bye.
Okay.